Almost all nursing homes are experiencing difficulty hiring staff. I have similar, some similar data for Ontario, but I imagine it's very similar in Ontario. Hugh is shaking his head, so I think it's probably true. More than half of nursing homes in the US are having to limit admissions due to staffing shortages. That's a big issue in terms of keeping nursing homes open. And more than 2/3 of the homes in this survey were concerned about having to close their facilities because they couldn't get enough staff. So big issue. And I just went to get a sense of what's happening in Ontario. I just went to the Globe and Mail and the Canadian Press and got a few quotes. I'm sure this is well known to you. Nursing shortage in Ontario remains despite push to hire. The CNO, the Nurses Organization, reports that RPNs that are working in long-term care settings has dropped from almost 40% in 2016 to 31% this year. Again, the bulk of the workforce. The Canadian Press says Ontario will be short 33,000 nurses and PSWs in 5 years. Ontario, because of that, will have less hospital capacity, similar home care capacity, interesting, I don't believe it, and less long-term care capacity in the coming years compared to what it had just a few years ago. This is from a report from Healthcare Policy Journal that shows graphically the gap, and particularly in PSWs and RPNs. And I would imagine this is conservative, just knowing all the shortages. And this is 12 years from now. So, and again, the PSWs are the ones who do most of the heavy work in nursing homes. Persistent quality of care issues, both in the United States and Canada, it's clear. In the United States, it's federal legislation, regulations. In Canada, of course, it's provincial that mandate, for example, periodic surveys. That's where deficiencies come there. So the surveys come in, you all know this. If not, this is a 2-minute review. Surveyors will come into the home, they look for deviations from standards of care. On publicly reported quality measures like prevalence of pain or the prevalence of pressure ulcers or depression that's not treated or functional loss, et cetera, et cetera. And then in the United States, at least, deficiencies can impact star ratings. Every nursing home in the United States has anywhere from 1 to 5 stars, and it's meant to inform the consumer. Is this a good nursing home? It's not. It's based on deficiencies found in the survey. It's based on how you do on those quality measures. It's based on staffing ratios, et cetera. Something that, Andrew, you should push for in Ontario. Maybe they're doing that already. So in the United States, this is from the Kaiser Family Foundation. I just want to give you kind of an overview. Average deficiencies per nursing facility, 2015 compared to last year. You see they're going up despite all of the regulations, all of the mandates, all of the intensive surveys, that we're still having persistent quality issues. And in fact, the share of nursing facilities receiving a deficiency for actual harm or jeopardy, which is the worst, remains high in 22% in 2022. So that's in the US. This is from the Office of Inspector General of a couple of years ago, basically saying the same thing. In 2018, you can see the total number of complaints has continuously gone up over the years. And many of those complaints are prioritized as high priority, about the same as it was 7 years ago when this was taken. I was trying to look for something similar in Ontario, and this article came to my attention. They were trying to look at quality indicators as predictors of future inspection performance. Not exactly what I'm talking about, but I wanted to talk. They had 594 facilities, had a total of almost 1,700 inspections, total of 6,000 citations, a median of 7 citations per facility, which is very similar to what we saw in the US. So again, the same trends are happening. The bottom line, if you're interested, there's only a weak relationship found between how a facility did on a QI and in future inspection performance. That's a whole nother talk. By the way, the slides will be available to everyone, right? So yeah, don't worry if you miss one. There's been no shortage of recommendations on how to improve quality, both in the US and in Canada. The nursing home, things changed in the US in 1986 when there was federal legislation called OBRA, Omnibus Reconciliation Act of 1986, that introduced the new nursing home reforms back then. Then there have been several Institute of Medicine reports and Office of Inspector General reports, basically saying we still have these quality issues. In Ontario, I looked at Health Quality Ontario site, and it's funny because it's so much, it feels so much more comfortable on that site than when you go to CMS in the United States. This is my own personal interpretation. That in Ontario, Health Quality Ontario says, we want to work with you to develop quality improvement plans. And here's some recommendations on how to do that. Recognizing that we have problems, just like in the US, with too many antipsychotics or the fall rates, restraint use, pressure ulcers, but it seems like a much more user-friendly approach. Now, whether it's any more effective, I don't know. And then in the United States, I mentioned this National Academy of Science, Engineering, and Medicine report called the National Imperative to Improve Nursing Home Quality. It's basically a continuation of what was the Institute of Medicine reports in years past. And this is what it looks like. You can download this if you're interested. It's free. So I'm bringing this up because remember I noticed that I had that slide on the centrality of the workforce in nursing home. You didn't see physicians listed there, did you? Because I wanted to hold that discussion till now. I think the physician role is underappreciated. Not only me, I think many people do. In this national imperative to improve nursing home quality that I just mentioned, they actually make the point. The physician role is important. Legislative and regulatory mandates define the role of the attending physician and the medical director in the US. They recognize that physicians manage the care, all resident care. Everything has to go through the medical provider, from admission to discharge to transfer. Even in the United States, there's what's called an FTAG, which is a citation that you get if you're not fulfilling the medical director role. So 605 pages in that report. 2 talk about the physician. There's another 2 that talk about the medical director. Now, this is not a politically correct thing to do. When I present this slide to others, they say you don't understand the report. It's there are other things about the physician. We don't know much about the physician, etc. I don't buy it. And I think it's what I call the Dangerfield effect. Now there's a few of you that get this, but all of you, the rest of you are too young. But there was a comedian called Rodney Dangerfield who looked like this. That's Rodney Dangerfield. And looks like he's got hyperthyroidism, doesn't he? But he would always get up there and he had a big red tie and say, I get no respect. But that's basically what I'm making the point. Physicians, I think physicians are often an afterthought. It's my opinion, but I do think there's some reason to believe that. They're generally absent from policy discussions that impact long-term care. It's low priority in the United States. The CMS is the Center for Medicare and Medicaid. They control regulations and oversight in nursing homes. For example, if I said I want to know who the medical director is for a nursing home in Idaho, I'll give you the address. They can tell me what the star rating is. They can tell me the staffing issues. They can tell me the survey deficiencies. They can't tell me who the medical director is. There is no repository. And I heard last night, there's no repository in Ontario either. Is that correct, you?
No, there is none, but only
Is there?
the government holds it.
Only the government. But as a citizen or a researcher, I can't get it. We also know that COVID, I think, highlighted the issue that the quality of care that is administered in nursing home is extremely variable. And we saw this with COVID. There's limited research regarding the impact of physicians on quality. One of the reasons I'm here and have the opportunity to work with leaders like Andrew and others in the room is so we can have more insight on these issues on care delivery. And physician practice is often unaccounted for when you look at other studies that look at provider outcomes. So I'll give you an example of that. We recently published an article, a scoping review on physician practice characteristics influencing nurse practitioner physician care in nursing homes. So it appeared to us that while, and I'm not downplaying the role of the nurse practitioner, they do a wonderful job. And the purpose of this was not to change the overwhelming opinion that nurse practitioners provide excellent quality and they're a critical element of the workforce. But we wanted to see, did anyone in these studies that looked at nurse practitioners in nursing homes and outcomes, did they take into account the physician practice? And we reviewed almost 1,900 studies. The nursing home had to be at least 100 beds. They had to have at least one nurse practitioner. And they had to have some sort of quantifiable clinical outcome. The bottom line was, in none of those, I think it was 16 reports that we reviewed, in none of them were physician practice characteristics characterized. There were no physician practice variables were adjusted for with regard to outcomes, such as how many physicians were practicing in that nursing home? What was their total load? What was their practice like? How did they interact with the nurse practitioner? How many times did they meet with them? Et cetera, et cetera. So if you're talking about a study that says the nurse practitioner does X, Y, and Z in a home, and the physician, and the nurse practitioner cares for 100 residents, let's say, and the physician has a outside practice of 1,500, and they're caring for 200 nursing home residents in 3 homes, you can see where it's not apples and oranges. So again, not politically correct, but we did get it published. So all of this argument about, giving you the current state, the changing landscape of nursing homes, the persistent quality of care issues, here is my pitch. We need to raise the bar. We need to establish practice and accountability for standards for physicians, nurse practitioners, PAs as well, to ensure that we're giving consistent high-quality medical care. The thrust of my argument is that specialty recognition or specialty designation of some sort for nursing home physicians is a necessary first step in establishing and promulgating standards of care. I'm going to make the argument in a few minutes that maybe we should apply this throughout the long-term care continuum to assisted living or retirement management. And whatever recognition we come up with, it has to apply to people who are already practicing. We just can't say you have to have these qualifications and this certification and say the rest of you are out. That's not sustainable. So what do we know about physician practice in nursing homes? We know actually a fair amount now. In the US, they're using the jargon of SNFist versus non-SNFist. SNFist is a in the US, skilled nursing facility is really meant to apply to nursing homes that cater to rehabilitation short stay. But many people talk about nursing home as SNFs. So that's the jargon they're using. But in the US, there's a short stay population, a long stay population. We won't get too much into that. So the busy slide, I just want to, and the data is up to 2017. Many people define a SNF as if 80% or more of their practice is solely devoted to nursing home, of their billing, their Medicare billing. And you can see that those who are greater than 80%, it's a small number in 2018. This has grown, 2017. You see 2,500 docs could be classified in the US as SNFs, but almost twice as many nurse practitioners. And that's a trend that's coming to Ontario, I'm sure. So what we see here, this is a recent article by James Goodwin and his group in New Mexico, that this is a percentage of providers who now practice greater than 80%. So of all nursing home providers, you know, getting to be near half are practicing what some say is full-time in nursing home. And just to make the point that if you're going to see a physician as your primary care, or MRP, you know, for Ontario, you're likely to see a nurse practitioner as a part of that team, or maybe nurse practitioners who are practicing independently. So the current data is an average of 45% of all nursing home residents are seen by a provider who works full time. So that's been a real shift in the last 20 years at least. And there is some evidence. I cited one review article that we did a couple years ago that goes through some of the data. Decreased rehospitalization rates, more visits on site as you would expect. Increase in successful discharge to community, better management of medications. Maybe not so clear that it's saving money in terms of Medicare, but there's some flags that indicate that there's positive benefits with this sort of SNF practice. And who are these? This was a report in JAMDA a couple of years ago that based on a 20% national sample of beneficiaries. Again, the data is a little old. Basically, only 12.5% of physicians who bill Medicare in the US. Medicare in the US is anyone over 65, that's Medicare. So only 12.5% did any nursing home visits. But the SNFs now in this study, they said it had to be 90% or more of their evaluation and management visits, accounted for only 1.1% of all physicians, but billed for about a third of all nursing home visits. So again, small number of physicians taking care of an increasing load. In this study, the SNFs tended to be a little older, more in primary care, foreign trained in solo practice. I want to call your attention to this bullet. Only 6.5% of SNFs specialize in geriatrics. In the US, you may or may not know that geriatricians often do primary care. So they act as consultants and primary care providers. Hold that thought for a minute. So here's physician practice in Ontario nursing homes. Some of you in the audience were involved with this study. You'll see the same sort of theme. In 2017, a little over 1,500 physicians were identified as responsible for the 93,000 residents across 626 nursing homes in Ontario. The mean age was a little younger. Majority were male. Almost all were GPs or family physicians. In the US, there's a split between general internists and family docs. Average of 22 years in practice, so these are mature clinicians. The majority practice in communities with over 100,000 people. The majority practice in one facility and 21% in two facilities. So you don't see, one doc going to 5 homes. It's usually 1 or 2. And what we know, we talk about the definition of SNFs, if you're greater than 80 or 90% billing in nursing home, that's an element of commitment. It's not the whole thing. Darley and others are looking into this. But 33% of nursing homes had 3 or 4 different MRPs. So still fairly close staffing. 29% with 5. It's not unusual. It used to be not unusual in the US where you'd see 10, 20 attending physicians carrying, this one has a couple patients, this one has 5. The medical director has 30. So you see this trend changing. This is an interesting statistic. In Ontario, the physicians were responsible for an average of about 86 residents. In the US, it could range to hundreds, depending. And if you're in a smaller community, you have fewer residents, 43. The proportion of total OHIP billing attributed to the nursing home. So at least 20%, quintile 5, 70% of their billing was nursing home. So you're getting the same sort of SNFist picture here in Ontario. And this basically gives the same thing. 51% of the total physicians were responsible for 90% of the residents. Small number of physicians taking care. Now that hopefully is giving better care. It's getting to the specialty argument, but we'll see. Let's continue the story. So many would ask, well, aren't these SNFs de facto specialists? So, what am I arguing here? And as I alluded to earlier, the definition of SNFs is based on percent of practice devoted to nursing home. It's a single component of commitment. We've made the argument that commitment, organizational structure, and competency are other elements that link physician to quality. And I did mention that most of the outcomes are generally positive, but it's mixed, and the differences are not huge. Well, could we look around the world and see, well, maybe people are doing this correctly? Well, we know the Netherlands is the only country that's ever had a nursing home specialty. They call it elder care specialists now because they're doing more home care and more consultations. But in the Netherlands, they have a residency training that's now 3 years that's solely devoted to chronic long-term care. I bring it up because I don't think there's any chance that model will ever be adopted in the US or in Canada. There's just not enough of a push. Professional organizations, the family practice organizations in Canada and in the United States, it's not on their radar. Interestingly, there are no studies comparing outcomes in the Netherlands before and after they developed the specialty, because wouldn't that be nice if we had an outcome study that said, once you develop these specialties, the quality improved markedly. There is no such data. However, we do know that the hospitalization rates for nursing home residents in the last year of life in the US are more than double in the Netherlands. Now, that's a bigger story, a lot of that's cultural, but there's something there. Well, aren't geriatricians the answer, at least in the United States? And I'm showing this maybe a little out of context, but this was an article that I've been bringing up to many of my colleagues in the United States, entitled "The Paradoxical Decline of Geriatric Medicine as a Profession." Now, in Ontario, Canada, geriatricians don't usually do primary care; they're consultants, so it's not as I don't think it's applicable. But Jerry Gurwitz wrote this article in JAMA and made the point that decline in board certified geriatricians from around 10,000 23 years ago to about 7,400. Despite the demographics that we all know, despite the aging population, despite the fact that we're seeing a nursing home population that's growing frailer, et cetera, et cetera. Now, there's a lot of reasons for that. People are retiring, but a lot of people are just not recertifying. They don't see a value in having that certification. The big point here is there are fewer trainees in the pipeline. Last year, less than half of the fellowship positions were filled in the US. That's the lowest percentage of all the 71 specialties in the US. That does not bode well for the next 20, 30 years. Who's going to take care of me? And that's, within a few years. There are few on the academic side. There are few fellowship trained geriatricians pursuing National Institute of Health funding. There are a lot of reasons for this. A lot of the foundations that used to support geriatric programs are no longer supporting them, such as the Hartford and Reynolds. Importantly, and I think this applies to Ontario and Canada, is there's inconsistent training requirements both in medical school and residency. So if you don't have a role model or a good mentor or at a site of where geriatrics is being provided, you don't see that, then you're not going to be attracted to the field. It's as simple as that. We also know in the United States is relatively poor compensation relative to other specialties. In fact, there's one article years ago that the geriatricians often cite that say, well, geriatrics as a specialty, they're the happiest. Probably true. But they get paid the least. So, and there's an article recently that said if you do a fellowship, you're going to lose money. It's not going to make any higher value of your income down the road. What I think is most important, and this is worldwide, it's ageism among students and residents. We could talk another hour or two about ageism, but it affects all of us. And again, if you don't have the mentors and the experience of seeing how geriatrics is practiced well, and culturally, you're already disinclined to want to treat older adults, you can see why no one's interested. I am a glass half. I have a slide with glass half full and empty. I should have thrown that earlier because I'm glass half full usually. So how do we move forward? If you believe that I'm making a rational case of specialty recognition, in order to do that, we're going to need evidence that specialists deliver better care, because you're not going to change policy unless you can prove to government that you're going to save money or improve quality or something. Many of you may know that the outcome measures that are mostly used in nursing homes are based on MDSY data that are very good. Those are the publicly reported quality measures that you hear about all the time. They're important and informative, but they only paint us part of the picture. What we want to know is, and for example, a lot is talked about overuse of antipsychotics or too high of rehospitalization rates for nursing home residents. But are they provider specific or are they more system level specific? So sometimes you can say, well, antipsychotics, the doctor has to order that. It must be the doctor's responsibility. Well, you get a call at 11 o'clock on Friday night, patient's agitated, is hitting the nurses. You need to order something. So the doctor orders an antipsychotic. Yes, the doctor is part of that decision making, but a lot of it is system level factors that go into the ordering. And you can say the same thing for many of these MBS measures. I mentioned we're talking about competence now, skill set, experience. The National Academy of Medicine in the United States several years ago actually made the point that we need to demonstrate competence in the care of older adults as a criterion for all licensure certification and maintenance of certification for all healthcare professionals, not just the doctors, the nurses, the therapists, everyone. So it's not like this is a new concept. It's not. In fact, I often quote this article by McLean in New England Journal of Medicine a few years ago. They're making the same point. The next generation of performance measurement should not be limited by the use of easy to obtain, i.e. administrative data, which is MDS, or function as a standalone retrospective exercise. Instead, it should be fully integrated into care delivery, where it effectively and efficiently address the most pressing performance gaps. And in fact, that's a lot of the work that Darlene and Andrew and others are doing now. And in fact, and don't worry about it, this is a busy slide, but a lot of the work that we've been doing have been trying to identify what quality measures can we come up with that are actually directly linked to the provider, physician, or practitioner. And we've come up with a number of them. They're not something you can grab off an administrative data set like MDS. You actually have to go in the chart and look and see. It's a lot of these are process-based. For example, if a nursing home resident falls, then we would expect, based on best practice, that the physician should see the resident within a specified period of time and determine why did the patient fall, unless it's recurrent. Did they do a neurologic exam? Did they check the blood pressure, lying and standing? Did they review the medications? Very straightforward things should be done. That's the sort of process outcomes that we're looking for that we think are a measure of competency of medical providers. We're working hard now to operationalize those and try to pull them out of electronic medical records. So we can use those, we can use them and they'll be accepted by the industry. So specialty recognition in the US, I think we need to formally recognize nursing home providers with a proven skill set and commitment that, like in the Netherlands, can drive change. We need to demonstrate that value add of post-acute long-term care specialists based on quality, which I was just mentioning, and cost. Then I think, now this is testable, I don't know if this is true, that if the nursing home sees better quality and cost, they're going to want to deal with those providers versus someone else. It will also shift government policy if we give them compelling evidence. And that's our work for the next few years. In California, they require certification of all nursing home medical directors through AMDA, which is a huge step. And not based on a lot of data, but there's one study in 2009, I think, that showed medical directors certified medical directors do a better job. Well, many of you, I didn't start to 8 after, so I'm going to try to finish quick. Hospitalists in the US in 2010 were granted focus recognition, a form of specialty recognition by the American Board of Internal Medicine. They didn't have a residency or a fellowship, so that's why they had this designation. Could we apply that to post-acute long-term care medicine? Maybe that's a paradigm issue. Unfortunately, only a handful of hospitals, 12%, currently seek that focus recognition. They don't see any value in it. So they built it and no one came, basically. So I'm not sure, post-acute long-term care, there are fewer clinicians than in hospitals. It's not going to work. I think a more pragmatic approach would be to look for the Society of Post-Acute and Long-Term Care Medicine, which now has the possibility of an Ontario, a provincial chapter. So in Ontario can participate in a national organization like this. They have already a track record of creating a credential for medical directors. Why don't we do the same for attending physicians? We've already we've already identified core skills and activity of nursing home attending physicians that mirror AMDA competencies. So a lot of that work's been done. I think OLTCC, Canadian Medical Directors, could be doing the same thing. We could do this together. So that's a call to action. Yes, sometimes it's like Sisyphus rolling that stone up the mountain and it just keeps coming down. But we got to keep trying to push. So let me spend the last few minutes and extend this logic, I hope, this rationale to retirement homes, assisted living in the US. Does that rationale apply? And if so, should we be talking about similar processes of care that have been talked about in nursing homes to retirement homes? The answer is yes. So you can fall asleep, have another piece of pizza. But that's the argument. So we've written about this a little bit. Because when you look at selecting an assisted living for retirement home, what do people look for? They look at, are there nursing? A lot of people just look at the aesthetics, that fancy dining hall and the fancy rooms. It's important, the food, activities, how much it costs. Rarely do people really start to focus on who's providing the medical care. That's just not part of the equation. It should be. And you should ask who's doing it, how often do they come in, when do they come in, etc. So much like the discussion we had over the last few minutes in nursing homes applies equally as well in retirement homes. It's a geriatric perfect storm. Older residents with increasing medical complexity, frailty. Many of these residents are in transition, going from community to retirement home to hospital back. Some go to nursing, and variable social supports. And like in nursing homes, the doctors who are caring for people in retirement homes, many of them excellent, but there's a lot of variability. And a lot of them do this, unfortunately, on a volume basis to make money. At least in the US, I have to think that's happening in Ontario to some extent. No, we're here. Yeah. This was a report by Madison colleagues, many of them in the room, that looked at rates of health service use among residents of retirement homes, and making the point that residents of retirements are older, predominantly female, have a similar profile to those in long-term care homes. Residents, they have high rates of emergency department visits, hospitalizations, ALC days, but lower rates of primary care visits. So you have this frail population, but they're not probably getting the intensity of the care they need. Findings suggest a need for more coordinated models of care, kind of like we're talking to nursing. This is just an article saying that the growth of, in Ontario of licensed homes has been increasing dramatically, and they're now providing all the services to address those functional deficits that we saw in nursing. Majority of care in the US and in Ontario, Canada, is provided by community-based physicians. They're unlike the nursing home, at least we don't think so. There's not a lot of physicians that are practicing solely in retirement homes. Often it's a combination. We have no studies that has yet compared different practice types with outcomes, like we've been talking with the SNFs. In most states and provinces have rudimentary regulations regarding medical care standards. It is in the United States, every state's different, and it's nothing like nursing homes. It's a Wild West. So we know a little, there's one study that looked at AL specialists in the United States. They only found 600 physicians that were comparable to SNFs, called AL alphas. I don't know what you call it, but it's going to be a trend. Probably you're going to see more and more people going to go to retirement home. A friend of mine in Florida said, these are the qualifications you need to practice in retirement home. You need to drive a Lexus and you need a stethoscope. That's it. You don't need any other trade. Not say that I'm going to cheat. Maybe a BMW is okay. So using the same lessons from the nursing home, we should be looking at commitment, yes, competence, organizational structure. I mentioned medical direction is important. We have that one study that the certified medical directors do better, and they're sponsored by AMDA. I think there's a real opportunity and a benefit when the physician or nurse practitioner is on site. You can work with the nurses and the team. You can find, more about your patient regarding function, behavior, et cetera. It's a much better way to practice. More timely diagnosis and treatment of chronic conditions when you have on-site care. So I'll finish up with 4 proposals. This is to improve, reimagine medical care in retirement homes or assisted living. And again, I say this with a deep conviction, but not necessarily a lot of evidence yet. All residents should be seen on site and round with the nursing staff, much like we do in nursing homes. Again, provides value insights into the resident's social milieu, function, mood, relationships, allows for a scheduled rounding with nurses, facilitates scheduled visits for each resident every, I said 3 to 4 months, kind of like a nursing home, because of the comorbidity and frailty demand. All communities should be staffed by medical providers, whether it's physician and NP or physician assistant, that are committed and experienced. You know, again, the specialty focus. We need to take into account how big your practice is, how much is long-term care, and how much of other things you're doing. We think a closed medical staff gives you better care. Practice size impacts efficiency and rounding schedules. Importantly, I would propose that we establish a medical director position for retirement homes. The industry does not want this. Government is influenced by industry, and so far will not go this route, either in the United States or Ontario. But this is something I think we should do. Then you can develop policies and procedures that will be consistent and relate to medical care standards, standardization of practice, set credentialing standards. So again, it's that Lexus stethoscope. Maybe we should be a little more in the weeds with who we bring in. Participate in quality improvement. And finally, medical staff, all medical staff should be involved in quality assurance improvement in the nursing, working with the medical director. It means that we should identify quality metrics that everyone uses in retirement. That's a big issue. Right now, it's not like the nursing home would probably report quality metrics. They don't really exist in retirement. We need to do that. So next steps, and this applies both to the nursing home side and the assisted living. We need empiric evidence. What is the optimum physician to resident ratio? What's the ideal frequency of visits? What are the medical directors most effective? Which payment arrangement is most effective? Capitated, fee for service, salary, and what are the roles of nurses, NPs, and PAs? There are a lot of challenges. People don't want to over medicalize retirement homes. Well, it's already happening. They don't want to make it look like a nursing home. I would agree. One size doesn't fit all. The industry does not want more regulation. These are huge challenges. Can a small community afford a medical director? If we build it, will they come? Will AL leadership, nursing residents, or families appreciate the benefits? Will they force the change? So all these things are going to be an issue. So here's the end game. When you enter, I would say, a nursing home or a retirement, you'll be cared for by a clinician who has the requisite skills and experience to care for your needs. The clinician will visit you in your apartment if it's a retirement home, or maybe in your room in a nursing home on a regular basis and work closely with nursing staff to provide needed care. The clinician will understand the post-acute and long-term care landscape and be adept at navigating through it, the transitions piece. And the clinician will meet high standards of care as defined by the quality metrics that we need to develop. So we do have time for questions, either from the Zoom audience or here, and I do appreciate your attention. And again, take any questions or comments.
Sure. So, I mean, first of all, thank you for addressing assisted living. I know I'm on Ben Schlegel's online, so is Rhonda Collins. This is an area that several of us scrambled in 2000 to try to figure out, because as you said, it's the Wild West. It's even more wild here for sure. I guess I love the idea of enhancing everything that you're talking about from the long-term care side about a certification. The Dutch model, they actually tried that here in Canada, where we have care of the elderly. As I think someone who just came in pointed out in the chat, But we tried to make it into long-term care, and our national family physician said no. So it was tried, there was pressure, they just rather said no. And I guess I'm interested in continuing doing it. I invested in that COE. Yes, it didn't increase my income, but it gave me so much more to offer. And I guess I'm wondering what your thoughts are on pay for performance. Because I love everything we say, let's keep going that way. But I wonder your thoughts about that avenue as a way of incentivizing certain quality. And I'll throw something out like family meetings, getting physicians or nurse practitioners to the family meeting. You make over 90% of those, here you get an additional payment. At least in Ontario, we have that for primary care in cervical cancer screening, breast cancer screening, child immunization, lots of different things. The only thing we have for this population is flu shots. And I wonder what your thoughts are, pay for performance as an incentive.
I think a pay for performance, value-based care, you know, and other jargon, I think it's great, and it's in the details.
Yeah,
If you pick the right measures that you're gonna get paid for, I think you can have an effect. But I know the experience in many countries, United States, England, the value-based care based on the measures that they were using really didn't change practice significantly.
okay.
So, or to the better, I should say. You know, people will game the system too. And okay, I'm gonna focus on these quality measures that I get paid for, but I'm not gonna do these over here because I don't have time. But you're absolutely right. Conceptually, it makes a lot of sense. And we gotta pick the right one. And of course, we have to convince the government too, that we're picking this. You know, it's better to attend a family meeting and worry about your A1C, which is a measure of diabetic control, in a 95-year-old who is, you know, lying in bed, non-functional, to do advanced care planning, et cetera, which, you know, I know I'm preaching to the choir. So I think you're right. We just have a long way to go.
Mostly public.
I apologize for my misstatements about Canadian healthcare. I'm sure I made some.
So there's an interesting one around, we do have a form of recognition, which is the certificate of added competence in COE, care of the elderly, through the College of Family Physicians. And how is what are you suggesting different? Are you familiar with the COE designation? Okay.
Yeah.
That's a
No, and I think it's great, but a lot of care of the elderly physicians, correct me if I'm wrong, you know, have private practices, they're part of teams, correct? You?
It varies.
It varies there,
primary
but
care.
yeah, I mean, it's a nice paradigm. Now I'm going to ask the question because I don't know, I mentioned the decline of geriatrics in the US. The geriatrician cohort in Canada remains around 300, somewhere around 300, 330. Is the care of the elderly increasing, or is that static as well? Yeah.
You know, my piece is all about care of elderly, so I can speak to that a little bit.
Please.
No, we're seeing similar trends to what you were sharing during your presentation, and in some pre-publication work that I'm working on right now for my thesis, only 37% of COE physicians are NRPs in long-term care. So despite having a specialized training, and I think fitting with the Gearsmith's model, they're not the folks that we're seeing in practice there.
Yeah, that's very important.
I don't think.
I want to see that article.
Yeah.
I don't think long-term care is required in the COE certification. And you can either do it in residency, and even then, you could go through it and never step foot in a nursing home.
Yeah. I mean, how many medical students here at McMaster during their training go to I'm asking the question, I don't know. Go to a retirement home or assisted living or do a home visit with a medical provider. I know in Florida where I was, and in Rochester where I've been, it's extremely variable and it's not a lot. And then the same question from, you know, medical residency training. So does anyone know that answer for the medical students here? And you can apply the same thing to nursing students. Because we saw the nurse staffing issue, how problematic it is. they're not flocking to nursing homes. Yes,
I'm on Costa. Thank you for the presentation. Great. Just a few comments. There was a comment about this care of the elderly certification. And I think there is some overlap there. The population care of the elderly certification, whether that's done with training or grandfathering, a large population of that actually practices long-term care. So almost when they speak, there's a little bit of an overlap with long-term care clinician, the care of the elderly. However, there's a sizable, I think, number of clinicians who do community care. There's memory clinics, there are retirement homes, some scattered retirement home care. There will be one comment. The other one is about the medical director certification. So in Ontario, similar to California, it seems like it's mandated to have medical director course certification, which is within the first year of your studying practice.
I think 3 years in California.
Okay, it might be different, but I think on the website it says different.
Okay, I may be wrong.
So it might have changed. And there's also encouragement of recertification, at least refreshment courses to be done for those in practice. Now, in regards to residents in training in long-term care, I'm not sure I can provide the overall umbrella picture, but there are scattered examples with students. I believe at McMaster locally. I know in my community, which is in field, we do longitudinal experiences for residents, as well as we do. I guess the care gathering, there's actually designated block when the care gathering training.
And what's the feedback? I think I know the answer. The feedback you get from your trainees, students, and residents about being exposed to long-term care. Is it an eye opener for them?
So for many of them, it is.
Yeah.
We're actually doing some surveys now, pre and post exposure to this experience. So it's fairly new. We have been having some organized manner, but right now it's in more structured way. So and again, there's also, I mean, a little bit different. I think in the US, as you mentioned, many geriatricians do primary care, which is different in Canada. So I'm not maybe that collaboration. I think it's happening in academic centers to prepare the elderly and geriatricians. I'm not sure in the community. It's a little bit different.
Thank you for your comment. You know, I remember at the University of Rochester, I was director of the fellowship there for many years. I used to question myself, well, the nursing home is really not that different. And I was downplaying it. And the fellowship was actually based at a large community, county-owned nursing home, Monroe Community Hospital. And I was always surprised by the new fellows who, were either internal medicine or family medicine. They come to say, I don't know what to do with these patients. I don't know how to handle this or that. So it made me feel good, actually. There is something to it. So yeah, we got a long way to go. I think, it's not only empiric evidence that we have an effect, which then hopefully will, changing curriculum in medical schools and residency programs is very difficult. You have to have very powerful evidence. Of course, I don't know what's more powerful than the aging population that we talk about.
Yeah.
And if anything, Andrew was telling me that many nursing homes are going to close. They can't find enough staff. They can't do the rebuilding that's necessary. Correct?
Yeah,
You're going to have less capacity.
there's a set of factors that are influencing that. Yeah.
Yeah.
Paul, thanks very much. On behalf of Mira, Jairus, and the Center for Integrated Care, Paul, thanks for coming to deliver the seminar. Thanks for folks online for attending and for the questions and thoughts. We'll make the slides available to the group and the recording available for those who couldn't join, although we started the recording just slightly late. Thank you.